Okay. So we don't have a test this week. Gave you guys a little bit of a break this week. But we are gonna go over some dose limits and some regulatory agencies that help us give us recommendations and how uh who gives recommendations versus who enforces those dose limits that um people have come up or these organizations have come up with. So the radiation protection standard organizations, we gonna briefly review these organizations listed. So what these organizations essentially do is they establish effective tissue dose or EFD and equivalent radiation type dose limits. Based off the recommendations from these organizations, limits are established through congressional act or state mandates. And then once the standards are established, national and state agencies are the ones who are responsible for enforcing them. So the first organization is the ICRP, which is the International Commission on Radiological Protection. It was established in 1928. It is the leading international organization that provides clear and consistent radiation protection guidance via recommendation on occupational dose limits and public dose limits. So this organization is international and it recommends, but it does not enforce. The next one, NCRP, this is the National Council on Radiation Protection and Measurement. It was established in 1964. This is a United States organization, but it's non-governmental, nonprofit, and it's a private corporation. So they basically review those ICRP recommendations and determine if they're going to incorporate them into the U.S. radiation protection criteria. Once again, this organization recommends, it does not enforce. The governmental agencies such as the NRC, EPA, they are the ones that enforce, but we'll go over the NRC and EPA. So they basically take what the NCRP recommends, or they take what the ICRP recommends. The NCRP says, okay, they recommend this, so we'll take that and we'll make that our standard. And then the governmental agencies are the ones that are like, okay, this is our standard, we have to follow it, and they enforce it. The NCRP came up with a LAR. So we know that a LAR is as low as reasonably achievable. And this organization came up with that specific principle. So next is UNSCAR, UNSEER. This is the United Nations Science Committee on the Effects of Atomic Radiation. This was established in 1955. This is also an international organization, and it formulates radiation protection guidelines using human and environmental ionizing exposures from radioactive material, radiation producing machines, and radiation accidents. So it basically takes epidemiologic data and concludes the risk assessments for radiation-induced cancer and genetic hereditary effects. Then we have the NAS/NRC, BIR. So this is the national, and the NAS is the National Academy of Sciences. NRC is the National Research Council Committee on the Biological Effects of Ionizing Radiation. So that's NRC BEIR. This is basically an advisory group that studies biological effects of radiation and risk assessment using routine and accidental exposure data. So that the information that we talked about like Chernobyl and Hiroshima, this agency basically would study that type of exposure. So they study exposure as far as early radiation work, like I said, atomic bomb, Hiroshima, Chernobyl. This is the group that studies that, or that studied that, and those biological effects of that fallout. The beer part was formulated in 1999 with the report Health Effects of Exposure to Low Levels of Ionizing Radiation. So this supersedes the 4 earlier reports that beer had that studies biological effects, associated risk of above mentioned accidents. So basically, this group studied those people that were exposed and kind of followed them to see what type of biological effects occurred due to that exposure. So just a breakdown of the organizations, the protection standards organizations. You have ICRP, which we talked about. This is international. NCRP, that's US. The UNSEER is also international, and then NASNRC beer is international as well. So now we're going to talk about the US regulatory agencies. So the United States federally limits the amount of radiation that can be received by a healthcare worker during a year. So these are some of the agencies that will enforce what the recommendations that the US has decided to follow. So these different organizations will enforce that. So you have your NRC. This is your Nuclear Regulatory Commission. This is a federal agency that oversees the nuclear energy industry. So they have the authority to control the position of atomic energy, the use of atomic energy, and the production of atomic energy. They have the power to enforce radiation protection standards, but they do not regulate or inspect imaging equipment and facilities. But what they do, do is they supervise the design and work mechanisms of nuclear power stations, the production of nuclear fuel, handling of expended fuel, and supervision of hazardous radioactive waste material. They also oversee the manufacturing and use of radioactive isotopes, and their use in research in the industry and nuclear medicine and therapeutic treatments. So if you have a nuclear medicine department in your facility, or if you ever work at a hospital that has nuclear medicine, a nuclear medicine department, they work closely with the NRC because we know nuclear medicine deals with our radioactive isotopes. So they work closely with them when it comes to the doses, and if they have any type of high dose therapies, or if they have any type of radiation spills, they work with that commission. They have to have documentation and all that stuff. So agreement states. So your agreement states basically are states where the NRC agrees with them that the state is going to be responsible for licensing and regulatory use of radioisotopes and certain radioactive materials. So basically, these states and the NRC have an agreement, and the NRC says, hey, we're going to let you all control your licensing and regulating of radioisotopes. Your non-agreement states, what they do is work alongside the NRC to inspect and enforce the radiation protection regulations. So they just basically work in with the NRC. And then you also have some states that may legislate regulations above and beyond what the NRC mandates. So you all are in Texas, and we see right here the Texas agreement state. Somebody has an open mic. Okay. So Texas is an agreement state. So what that means is that Texas has the Texas Department of State Health Services. So this is the DSHS. It has been involved in radiologic health sciences since 1947, and their basically mission motto is that we strive to prevent unnecessary radiation exposure to the public through effective licensing, registration, inspection, enforcement, and emergency response. So basically the state license that you all have to obtain comes through the DSHS, the Texas Department of State Health Services. So next is Environmental Protection Agency, EPA. You might have heard of the EPA before. President Nixon established the EPA in 1970, and basically it is responsible for protecting the health of humans and safeguarding the natural environment from industrial practices and harmful waste disposal. They oversee the development and enforcement of radiation pertaining to control of radiation in the environment, such as direct relevant federal agencies, environmental monitoring, and oversight authority for areas such as action level of radon. Next is the FDA. You guys may be familiar with the FDA as well. FDA, this is the U.S. Food and Drug Administration. So it not only deals with the food part, it does deal with the drug part. FDA has its hand in a couple different things. One big thing in imaging is that they work closely with mammography equipment. If you are planning to go into mammography, you know, it is mammography is very regulated, and it's the reason why it's very regulated, because the breast cancer, number one, is one of the leading causes of death in women in this country, but also the equipment has to be up to a certain standard because you are trying to detect the smallest lesions for early detection of cancer, and you have to have specific equipment. It has to be calibrated specifically. So FDA is very involved in mammography, very strict on those regulations. They can come in and do an inspection if your equipment is not up to standard or is not passing quality. They can shut your mammography program down. So under public law 90-602 of the Radiation Control Health and Safety Act of 1968, the FDA conducts product radiation control. They run that radiation control program that regulates the design and manufacture of electronic products, including diagnostic X-ray equipment and mammography equipment. They conduct on-site inspections to determine if the standards are in compliance, like kind of like what I just said, and ensures protection of occupational and non-occupational exposures due to faulty manufacturing. So that's why they're so involved in mammography, because that equipment has to be precise, calibrated, specific way, because of the sensitivity of the test and what they're looking for. So February 2010, there was a white paper published, basically initiative to reduce unnecessary radiation exposure for medical imaging, which stated that patients have the right to be informed by imaging exams done at the right time with the right dose. If you taking the patient care class, one thing we talk about in that class is the 6 rights of medication administration. This kind of falls in that, but it falls under that, but it falls in line with just imaging, period. Making sure you're using the right, or you're completing the right imaging exam. So you're doing the correct exam at the right time using the right radiation dose. So in conjunction with its partners, the FDA intends to take action to, number one, promote safe use of federal imaging devices, support informed clinical decisions, increase patient awareness, and then optimize patient exposure to radiation from certain types of medical exams, and thereby reducing related risks while maximizing the benefits of these studies. So next organization we'll talk about is OSHA. You may have heard of OSHA too. OSHA is the Occupational Safety and Health Administration. OSHA, basically, when you think about work safety, OSHA probably is going to be more known kind of in the construction industry or the manufacturing industry, because they have a lot of standards to keep the people that work in those industries safe. But they kind of cross over to radiation and radiation exposure, because a part of OSHA does regulate occupational exposure through part 1910 of Title 29 of the U.S. Code of Federal Regulations, which regulates the right to know concerning occupational hazards, including hazardous substances, infections, agents, ionizing radiation, and non-ionizing radiation like background radiation, like ultraviolet and microwaves. And it regulates training programs in the workforce. So if you have a program to learn about radiation, OSHA probably has something to do with it, but it's basically there when it comes to occupational exposure. So overview of our U.S. regulatory agencies, you guys can view that. Our NRC, they deal with nuclear energy. They enforce standards. They also work with radiopharmaceuticals or radioisotopes. They publish rules and regulations. Our agreement states they enforce regulations via the state health department. So they NRC is giving them permission and told them, hey, you guys can control your standards, and they enforce it with the state health department. EPA, they develop and enforce radiation regulations concerning the environment. The FDA, they produce radiation control programs for electronics, X-ray equipment. And then the OSHA basically monitors the employment industry and their occupational exposure. So next, we're going to talk about the Radiation Safety Program, Radiation Safety Committee, and then Radiation Safety Officers. So if you have a department that deals in radiation, more than likely you have a radiation safety officer at some point. You should have one. And you probably have a radiation safety program. They should be holding meetings, and there should be somebody. If it's not somebody dedicated to that role, then somebody is probably doing that role in conjunction with some other type of role. So when you have a radiation safety program, what this means is that this program ensures adequate safety of patients and radiation workers. So it says every facility should have an active radiation safety program. What it tells us is that administrative personnel must provide funding in their budget to have this program. They oversee the development of the policies and procedures of radiation in the department, and then they provide the equipment needed for starting and for continuing the program. So we see what is radiation safety. Radiation safety is a combination of safe practices and precautionary measures for working with or near radiation. So your radiation safety program, just another comment on that, they should also be the ones responsible for your badges. So then Radiation Safety Committee. Not every facility has to have this, but usually if you have a bigger facility and they offer several different modalities, radiation producing modalities, they probably will have a Radiation Safety Committee. It's usually established by the facility. it imparts guidance for radiation safety programs, and it is NRC mandated. So like I said, if you have multiple modalities that have radiation producing equipment, or if you have nuclear medicine in your department, more than likely you have a radiation safety committee. And then with that radiation safety program, radiation committee, you should also have a radiation safety officer. This person is going to oversee that radiation program, the radiation safety program. If anybody has any type of overexposure, your radiation safety officer should be the one who investigates. If you have any type of radiation tracking software, your radiation safety officer is the person who should be over that. If you have equipment that has to be serviced, and the physicist has to come in and do any type of checks on that equipment that are mandated before you start using it again, your radiation safety officer is the kind of person that will coordinate that. So it lists that your radiation safety officer can be a medical physicist, it can be a health physicist or a bioengineer, it can be a radiologist or another qualified individual. And this radiation safety officer has to be designated by the facility and approved by the NRC and the state. At our facility, we have a dedicated radiation safety officer. And if I'm not mistaken, he is a health physicist, or the people that work in that department. We have a team of 3 people that work in the department. They are considered health physicists. Usually the medical physicist is the person that comes in and checks the equipment. But in the interim, when we went through a period where our radiation safety officer retired, so one of our radiologists or nuclear medicine physicians acted as the radiation safety officer until we could hire someone else. So some other things the radiation safety officer is responsible for is developing the radiation safety program and following internationally accepted guidelines, ensuring all persons, especially those who are and could be pregnant, are adequately protected from unnecessary exposure. So if you're a female technologist and you declare your pregnancy, your RSO is the person you will declare it with. They will give you education, and then they will give you a second badge to for fetal monitoring. They also manage grant authority to implement and enforce policies. They review and maintain radiation monitoring records for all personnel. So your radiation reports, if you've ever seen it, hadn't seen it, your radiation safety officer is your point of contact for that. And then they provide counseling for personnel, like I just talked about, those who their dose may be above the set limits, pregnant, occupational workers. They may even work with, they do training, fluoro training with people who work with the C-arm, like your surgery staff. They may do training with them, as well as manage their dosimetry badges as well. So the Radiation Control for Health and Safety Act of 1968, why is this important? It was enacted by Congress to protect the public from hazards of unnecessary radiation exposure from such things as electronic products, microwave ovens, picture tube color televisions. Those are the old school televisions. Y'all probably don't remember those because we have flat screen TVs now, but TVs did not used to be, they were nowhere near as flat as they are now. It was kind of a big deal to have a TV, and then if you had one, it wasn't one that was very small. And then also diagnostic X-ray equipment. So the act also permitted formation of the Center for Disease and Radiological Health, which is the CDRH, under the jurisdiction of the FDA, establishing standards for manufacturing of imaging equipment, installation of imaging equipment, assembly of imaging equipment, and maintenance of imaging equipment. Don't expect y'all to know these, memorize them. You just need to be kind of familiar with the different organizations. Nobody's gonna quiz you on it, and so you don't have to commit this to memory. So the Code of Standards for Diagnostic X-ray that was set forth by Public Law 90-692, and this, if I'm not mistaken, this slide is in this table is in your book. This slide also would be a good reference to study for the registry. So knowing the automatic limitations of a beam to image receptor, which is the positive beam limitation, PBL, the minimum permanent filtration, which is 2.5 millimeters of aluminum equipment of X-ray beam, reducing soft X-rays that only contribute to patient dose. So that filtration that cleans up the scatter, are those low dose X-rays that are not beneficial. Exposure reproducibility for any given KVP, MA, or exposure time less than or greater to 5%, exposure linearity and linearity difference of less than 0.1. Beam limiting devices for spot films and fluoroscopy between X-ray source and patient. Beam on visual warning during exposures, and both visual and audible signals when exposures are terminated. So basically, what that number 5 is when we're supposed to have a sign outside of our X-ray room that tells us when the X-ray is in use. So making sure that you actually have it in place and it does work. That's one part of that. And then manual backup timers for automatic photo time AEC exposure controls if automatic timer fails. All right, next, the NRC report number 116. And this sets the information, or sets the limits on annual radiation exposure. So it does give us limits for cumulative effective dose. So it tells us that the radiation worker's lifetime effective dose whole body is basically the individual's age times 10 millisieverts. So just say that you are 30 years old, you multiply 30 times 10 millisieverts. So it's telling us that your lifetime effective dose should be around 30 millisieverts at that point in your life. It does not include your radiation exposure from natural background radiation and exposure acquired because worker undergoing medical imaging procedure. So this is just your exposure, occupational exposure, healthcare worker exposure while you're doing your job. Does not account for the natural radiation, background radiation that you may receive just being, from the sun or just being out. Or if you yourself is having a medical imaging procedure. But it does include both your internal and your external exposure, the possibility of both. It gives us our occupational effective dose limits. So the NCRP says that we must ensure that our dose limits are no more than 50 millisieverts. So you want to try to get it less than 50 millisieverts. So this will be your annual effective dose to the whole body. So in 1991, the ICRP, remember ICRP is international, revised some recommendations. They actually went down to say that your annual effective dose can be as low as 20 millisieverts or less. So the NRC has not reduced, the NRCP has not reduced their kind of recommendation, but in the future they may. And these revised risks were estimated and derived from the reevaluation of the Hiroshima and Nagasaki incidents and increased number of solid tumors in survivor populations. So it gives us non-occupational effective dose and tells us that for those who basically have continuous or frequent artificial exposure. So say you're not a technologist, but you are an administrative person that works in a radiology department. It's telling us that their non-occupational effective dose should be around 1 millisievert. And then it tells us for those who have infrequent exposures. So like you come to an appointment with a parent or a child every now and again, or you yourself have to have like a chest x-ray annually. That's considered like an infrequent exposure. So that dose should be no more than 5 millisieverts. So for pregnancy, radiation worker, and embryo fetus dose, the NRC recommends that the monthly embryo fetus equivalent dose should be no more than 0.5 millisieverts. And then the maximum pregnancy equivalent dose should be no more than 5 millisieverts. And this also does exclude medical exposure and background exposure. So those limits does not take into account those two. And then educational and exposure for those 18-year-olds or younger. Their effective dose, annual effective dose should be no more than 1 millisievert. So they do give us some recommendations of dose limits for the eyes, skin, hand, and feet. The dose limit for the lens of the eyes is 150 millisieverts. And the reason why it's a little bit higher is because usually the distance that the lens of the eye is from the beam, and we know at a specific kind of dose that cataracts can occur. So that limit is a little bit higher. And then also for skin, hand, and feet, that dose limit is about 500 millisieverts. So a negligible individual dose, which is basically anything below the dose, kind of the dose limits that we just consider just not to even worry about. So an annual negligible individual dose is 0.1 millisieverts per source or practice. So this means basically that at this effective dose level, a reduction of the individual exposure is unnecessary. So basically what that means is that risk due to all the causes other than radiation are much higher than risk due to radiation. So basically we don't even, if the dose comes up at 0.01 or below, it's saying that you don't have to even, account for or pay attention to it. So here is a good slide to look at and study and actually study this for your registry too. One good thing about this slide is that everything is in millisieverts. So all you have to do is remember the millisieverts. But it breaks it down basically how we just talked about from slide to slide. Your cumulative effective dose, occupational, non-occupational, frequent versus infrequent, your pregnancy, your fetus, and then monthly and your pregnancy total, education for 18 and younger, lens of eye, skin, hand, and feet, and then your negligible dose. So this is a good slide to keep and make note of. So action limits. Technologist personal dosimeter reading should be significantly below a 1/10 of the maximum effective dose limits, even for those technologists who receive the most exposure. So purpose is to trigger an investigation when the limits exceed that or could uncover the reason for abnormal exposure. So if for some reason you start to get an abnormally high reading from your personal dose dosimeter. Some of the frequent causes of that is number one, unknowingly leaving your dosimeter in the x-ray room, um, or on the lid, hanging on the outside of the lid, and then it's in a room that they do procedures in. So basically your dosimeter is being exposed without it being attached to you. So that may cause a higher than normal reading. And then where the technologists stand during interventional radiography. We know that there's a area close to the machine that we may be exposed to a little bit more. We do know that our exposure when we are dealing with fluoro machines is dependent on, number one, if you're doing a C-arm, how the C-arm is positioned. Certain positions cause a larger occupational dose to the person operating than others. Um, and also one other thing that could cause an abnormally high reading is if you take your radiation badge home and you leave it in your car, that can cause an abnormally high dose as well. So next thing we'll talk about is radiohormesis. So radiohormesis basically is a theory about therapeutic radiation, saying that the radiation actually is helpful versus it being harmful. So this concept exists saying it's beneficial results in group of individuals being exposed to continuous radiation in small amounts. So radiation hormesis is the hypothesis that low doses of ionizing radiation within the region of and just above natural background levels are beneficial, stimulating the activation of repair mechanisms that protect against disease that are not activated in absence of ionizing radiation. So this kind of goes against everything that we have been taught, that, any type of exposure could potentially cause cancer. So this is a fairly new concept that is being researched. So they actually have done studies on the Hiroshima group, and it says basically the data seems to indicate that those that were survivors of Hiroshima with moderate radiation equivalent doses of 5 to 50 millisieverts, um, the equivalent of 1.5 to 15 years of natural radiation has reduced their cancer rate compared to the normally exposed control population. Additionally, 7 Western states with background levels higher than other states, approximately 1 millisievert per year, the residents experience 15% less or 15% fewer cancer deaths per 1,000 individuals than the US average. All this research, it is interesting. It's fairly new, so I do think that it needs to be followed a little bit more. But in the meantime, what we're gonna do as radiation professionals is stick to what we have been taught, and that is to always practice the ALAR principles, because we don't know how true this is. It needs a little bit more research before we can kind of agree to say that radiation, low levels or small levels exposure to radiation could be therapeutic. So fluoroscopy regulations. So FDA does come into this as well as mammography. So the FDA, their Code of Federal Regulations, CFR Title 21, Part 1020, deals with regulations regarding ionizing radiation producing products such as our fluoro machines. Part 1020, Part 331 deals with radiographic equipment. 1020.32 deals directly with fluoro imaging equipment. It tells us that our imaging equipment must have a primary protective barrier Our image intensifier on our fluoro machine can act as a primary barrier, but we also have that lead curtain there as well. That can act or be considered a primary barrier. That our exposure area AKR measurements averaged at least no more than 100 centimeters squared. That our SID should not be less than 30 centimeters or 12 inches. So our source to image distance should not be less than 30 centimeters or 12 inches. The area exposed or our field of view should not be greater than our image detector size. So if we have a 11 by 14 image detector size, that our field of view should not be larger than 11 by 17. And that continuous pressure must be applied to active fluoro dead man switch. So we have to have a dead man switch on our active fluoro. Then it also tells us about our automatic brightness control. Basically, remember, automatic brightness control is what takes over after kind of our KV and max has kind of the machine is giving all it can give. It's maxed out the technique. So your ABC takes control. So it tells us that should be no more than 10 Rankine per minute. It tells us our non-automatic brightness control should be no more than 5 Rankine per minute. That when we're using fluoro and cine on our fluoro machines, that our tube potential, our KVP, and our current, our mass should be continuously indicated and visualized. So it tells us that on the machine, we should be able to see our technique if we're using fluoro and cine functions on our fluoro machines. And that our source to skin distance, our SSD, with our stationary equipment in our rooms should be at least 38 centimeters. And with our mobile C-arm, it should be 30 centimeters. Then lastly, it tells us about our fluoro timer, that we have to have a fluoro timer, number one. This allows us to track the fluoro usage, that you get a maximum of 5 minutes exposure before a reset is required. And then you have to have an alarm or audible signal that lets you know when that 5 minutes exposure has occurred, and allows you to basically reset the device. All right. So that's all I have for you tonight. I was trying to kind of get you out of here quickly. Do y'all have any questions about anything that we went over tonight? All right. If not, then you can go ahead and type your name in the chat box. Y'all have a good rest of your night. Thanks, everybody.